videos from Coimbra, Fado from Coimbra, and now it's time to us to keep with the work, and it is with a great honor that I introduce you our next keynote speaker, Dr. Jason Farley. In the next 30 minutes, Dr. Jason will share with us experience and lessons learned from the COVID-19 pandemic management in the USA. And Dr. Jason is in a great position to provide us with this talk, as he is a professor of nursing, but he also is an infectious disease trained nurse, epidemiologist, and a nurse practitioner in the Division of Infectious Disease at the Johns Hopkins School of Nursing and Medicine. He is on the front line in the fight against COVID-19, heading the Baltimore City Health Department and Johns Hopkins Health System with patient testing efforts and PPA training. For COVID-19, he is co-leading a large population representative cohort study among households in Baltimore City with collaborators in the School of Public Health and Medicine. Also, he is director and founder of the REACH initiative, serving Baltimore City residents living with and at the risk of HIV and associated co-infections. And he is a fellow in the American Academy of Nursing, most recently serving as chair of the Emerging Infectious Disease Expert Panel. As a seasoned infection prevention expert, Dr. Farley was part of Johns Hopkins team evaluating the COVID-19 response in China at an affiliated institution, as well as country-level health system responses to tuberculosis and HIV. And he maintains a clinical practice as a nurse practitioner in the John Bartlett Special Clinic for Infectious Disease. So it's a great honor. Dr. Jason, please, we'd like to listen to your words.
Absolutely, everyone. Well, thank you so much to the organizer, Sigma, Dr. Lomba, and particularly large thanks to Dr. Ken Dion, who facilitated this introduction for the work that I do here today. I'm very happy to be coming to you from Baltimore. I'm going to share a series of slides with you that provides really a snapshot of some of the things that we're experiencing in the US, some of which I will add some additional anecdotes to based on our experience in Baltimore. So let me begin by sharing my slides here, and then we'll go through those. Throughout the presentation, prior to sharing, just so everyone's aware, please feel free to type questions into the chat box. Happy to spend time at the end of the presentation taking questions from the audience and the team, and Lurdes and others will help us with moderation of that after the discussion. So let me share this here. Everything looking good on that side? Yes. Great. Thank you very much for the lovely introduction. You're too kind, and it's very humbling. Today, this presentation will focus on an update of the U.S. status of COVID-19, the nursing response, and implications for our practice in the United States, and hopefully the exquisitely painful and challenging lessons that we are learning from our response and sometimes lack of response to the outbreak. So this is the city that I come from. This is Baltimore, Maryland. Many of you may know it from popular television series called The Wire. We are not all gangs and violence. We are a vibrant city that has a lot of flair, so much flair that you may have seen Baltimore in the media related to the current administration of the United States attacking our now late Senator Elijah Cummings related to the work that he was trying to do to in really fighting this administration around many issues. But particularly, I want to call your attention to a tweet by the administration that says that Cummings District is a disgusting rat and rodent infested mess, and no human being would want to live there. So why am I saying this? I'm saying this because the Baltimore Sun followed up with a wonderful article, "Better to have a few rats than to be one," in response to the administration. And ultimately, we welcomed the administration when they came to Baltimore with a giant rat. And I think that this is apropos to the way the administration has responded to this pandemic. Oftentimes in a seedy way, oftentimes in a way that is makes you question the integrity even further of the administration, and certainly putting the healthcare workforce at greater risk through many painful and erroneous and ill-informed decisions. So with that note of the flair of Baltimore and where I'm sitting in this discussion with you today, let's start in with our coronavirus response. We know that coronavirus is a wide variety of a family of viruses. There are 4 human types of coronavirus that cause part of the seasonal cold and flu spectrum of illness. Those are highlighted in yellow for you. We know that there are, so prior to SARS-CoV-2, 2 other forms of significant disease related to severe pathogenesis, and that is SARS-CoV-1, so a response that I had the fortitude and fortune of seeing up front in China during the original outbreak in the early 2000s, followed by MERS, or the Middle Eastern Respiratory Syndrome. Both have high pathogenicity but low transmissibility in compared to SARS-CoV-2, which is the newest form of coronavirus that we have discovered as a human pathogen. Much higher transmissibility, but in comparison, the mortality seems to be lower amongst these this virus compared to SARS-CoV-1 and MERS. Yet, we know that there is an exceptionally wide clinical spectrum of illness. We have people on the one end who are completely asymptomatic and may be a source of potential transmission, but ultimately have no real clinical symptomatology. We have people who have a milder version with cough, fever, and possibly myalgias, possibly loss of taste and loss of smell. And then we have the opposite end of that spectrum and a lot in between, leading to acute respiratory distress syndrome. And I've shown you this image here to the right to really just why this is such a painfully, looks like I have been muted.
We are listening to you, Jason.
We can.
Oh, okay. It popped up on my side that I was muted. Sorry. From the clinical perspective, what patients are actually experiencing with a severe acute respiratory distress syndrome is literally a filling of the lungs with fluid. So that shortness of breath and hypoxia that results from the immune response to the virus actually causes the patient to feel like literally they are drowning. We also see, as you can see with the red lining of this alveolar picture here, an increase in the actual size and thickness of the alveoli, which influences gas exchange as well. So you've got 2 different forms of issue going on here clinically. This circumstance is one of the main reasons why nurses throughout the world literally go into a patient's room as soon as a pulse ox may fall below 90% and prone them, because you're literally trying to move the oxygen demand, change the physiology of the lung, change the fluid placement in the lung, and help to improve gas exchange with proning of the patient. And when we look at the data here in the United States, we have now passed the grim marker of over 100,000 US deaths with over 1.6 million cases. You can see the distribution by proportion of the total number of cases throughout the United States. And like the administration has said, not all areas are equally impacted. Those in darker blue having the greatest number of cases, and Washington, D.C. and Baltimore highlighted with this little dot right here in the top right corner, just to orient you to where I'm sitting today. We also know that when we look at the graph on the right of cases by age, while we initially presented, and I'll show you prior slides, initially presented the idea that this was not a young person's disease, we failed to attribute the importance of young people who may not have a worse clinical spectrum serving as vehicles of transmission. And here's what our data looks like in terms of our overall cases by age out of about 1.3 million people to date. And importantly, this next slide is the most grim. Of those 1.3 million people that I referred to on the last slide, approximately 63,000 of those are healthcare workers. And we have experienced over almost 300 healthcare provider deaths that have been verified by the CDC. Those estimates go up to over 500 healthcare worker deaths if you look at the data coming out of the nursing union. This is an exceptionally painful moment for the health workforce, and it's caused lots of ripple effects in our response, caused lots of fear in our students who are not yet licensed for care, and has caused people to make critical decisions about the way in which they interact with their loved ones and family when they return home from the hospital. Now, how did we get to a circumstance in which that data, when we first found the infection in the United States, where we thought a different clinical picture was presenting itself, really persons in the upper ages of life, and I myself, as you know, an infectious disease epidemiologist, was called upon to discuss really what was happening with this epidemiology. And really the first cases in the United States were a mirror image of what was experiencing in China. And what you can see from this graph here is really that the patient's cough in that orange bar began one day prior to a subjective report of fever, and which continued for the first 7 days, and then ultimately leading into other symptomatology for this particular patient. Importantly, we have now seen patients whose PCR remains positive for weeks. We are also seeing patients who have recovered from a prior positive, who weeks later ultimately have developed what we believe to be new infection. And so what is happening in those circumstances are still under review, but we think it relates to the level of broadly neutralizing antibody that is developed and how long they persist in each person. Now, originally, we thought that individual cases were coming from China. But what we now know from phylogenetic analysis from New York City and others through this wonderful paper is that most of the cases were coming from the East Coast, were actually European strains that had come via travel, likely weeks prior to us identifying the first cases in California and the cruise ship associated cases that we know. So the phylogenetic tree, and the phylogenetic relationships with these patients in New York were exceptionally similar to the strains that were identified and being mapped and sequenced from our European colleagues. And this is a great analysis of how in pandemic circumstances, we make decisions and make assumptions based on a variety of different activities, including our administration's assumption that stopping travel from Wuhan, China specifically, and from China more broadly was going to be helpful. And then obviously travel from other locations throughout the world lagged behind. I myself was in Guatemala at the time in which travel restrictions were being administered and ultimately got out on the last flight being allowed back to the United States, but that was weeks after they closed the border to China. What we now know is that the R0 is certainly greater, the transmissibility is certainly greater in large gatherings. And I present you two exemplars from the MMWR, the Morbidity Mortality Weekly Report, that shows two primary cases on the left of this slide were individuals who attended church. It turns out that those two individuals were the pastor and his wife attending church having communion, shaking hands, greeting parishioners, and at least 35 of 92 attendees acquired COVID and 3 deaths associated with that. From those contacts in that church, it led to at least 26 additional cases and 1 confirmed additional death. On the slide on the right, this was an individual, a single index case, who participated in a large chorus singing. This was 32 confirmed cases and an additional 20 probable cases from a group of individuals who were staying at least 6 feet apart and wearing facial coverings during this group meeting. An extremely important finding, because we talk about how transmission occurs within 6 feet when we are doing our normal breathing and normal activities. But we do know that things like singing and running where there's heavy breathing may lead to increased transmissibility for someone with a high viral load who has high transmissibility. Importantly, these statistics and these data have not influenced the community response throughout the United States. If anything, there has been an emboldened reaction across the United States toward opening up and limiting the rules and regulations and restrictions for non-pharmaceutical interventions in the United States. This is despite the fact, and as I previously mentioned, our original messaging in the country was related to those in the older age brackets. So young people did not take the disease seriously. And then this is what happened to us in March of 2020 with spring break all along the Florida beaches. Despite the fact that 40% of patients being hospitalized in the United States at that time were between the ages of 20 and 54. So again, that college age group of people may not have significant morbidity or mortality, but they serve as a source of potential transmission. And if you look at Twitter specifically, who tracked individuals who were tweeting along the Florida beaches, they then showed where those individuals went back throughout the United States and really showed a wide dispersion across the country. And so what we've seen in terms of hospitalizations is, and this is data from March that supports that New York Times article from the CDC, basically showing that hospitalizations were occurring across age groups beginning in the 20s. ICU admissions were increased and higher in the older age groups, but deaths certainly were the greatest in our older age populations here in the United States. Suggestive that when we think about pandemic responsiveness, and we think about the sources of infection and the potential hospital bed utilization, we must message and provide critical messaging accurately throughout the pandemic. And that is something certainly that our administration in the United States has struggled with and continues to do so. So despite our recommendation for non-pharmaceutical interventions, masking, there is a big difference between recommendation versus reality. The Center for Disease Control and Prevention in the United States has basically been a defunct agency throughout this response. My personal opinion about the response of Dr. Redfield, who I do know personally, has been that there has been lackluster leadership that has been bent to the will of the administration. And I personally think that the CDC has really been absent in the response to this epidemic. As you've seen in the United States and through media, our CDC guidelines for opening up the United States were delayed, and that was principally due to administrative oversight and regulations. This is that image I showed you before from March of 2020, and just 2 months later, at Memorial Day weekend, a weekend to remember the fallen in the U.S. military, and the unofficial start of summer in the United States. This is the Lake of the Ozark image capturing individuals clearly not social distancing in the United States, in Missouri. So what do we know? What has Johns Hopkins and colleagues of mine told us about what we know is for the health workforce, which I think honestly mirrors the work of the general population. When you see the original impact of anything that causes psychological distress, including a pandemic disaster, you see this initial impact, this initial emotional low that occurs, that people are realizing and getting used to the new normal, that turns into this sense of heroism. The healthcare workers being applauded throughout the world has been just so heart-touching. Healthcare workers running out of retirement to respond. And that heroism has really led us into this sense of community cohesion initially in the epidemic. But we have clearly moved throughout the United States into this period of disillusionment. Lots of community stress and fatigue, really strong emotional responses to people being what they consider their liberties being restricted by the government, and ultimately leading to backlash throughout the United States and protests that have led to, in my mind, poor decision-making by leadership at both the state and the federal levels in terms of the decisions to open up many of the activities, despite the fact that we have ongoing hotspots and transmissions in locales that have decided to open up. And that brings us to the next part of how, when opening up and having new cases occur, the number of individuals that will be coming in contact with new cases goes up dramatically. We have yet to be able to significantly and substantially stand up full contact tracing in many jurisdictions across the United States. Our own School of Nursing, led by Dr. Phyllis Sharps, has been directly engaged with the Baltimore City Health Department, determining how our nursing students can be engaged in contact tracing efforts. Our School of Public Health as well, led by Dr. Emily Gurley for our public health students. And we've really been engaging our students in the response as much as possible. Obviously, clinical scenarios were extremely limited for our students during the early spring semester, spring semesters. We are now returning those students to clinical in January, and so that may impact their ability to do contact tracing and be part of that workforce. But what I show here is, on your right of your screen, is that an individual family who had a family gathering in Illinois, Chicago, Illinois, in late February and early March. And from a single case of illness, you can see the entire tree that led to 3 family deaths. There was a meal followed by a funeral, followed by individual contacts at in those events that led to a birthday party that led to subsequent exposures, all within a single family. And what we can see on the slide on the right, on the left of your image, is that the incubation period for confirmed cases in this circumstance was approximately 4 days. And so many were asymptomatic during the period of exposure, but they continued to transmit within their 2 family gatherings for a period of weeks, ultimately resulting in death of 3 family members. Now, I don't say that to victimize this family. People are making very difficult decisions and feel that they are asymptomatic in a period in which testing was exceptionally limited in the United States, and it remains so. But I want to point out that, when circumstances like this are occurring, think back to the pool in Missouri that I just showed you a few weeks ago. Think about contact tracing for the individuals in that pool and the people that they will come in contact with. It's literally becoming almost an insurmountable activity for the public health officials to work through as we begin to open back up. And the administration clearly said that everyone who wants a test can get a test. And I am here to say today that that is a falsehood. Everyone who wants a test can certainly and absolutely not get a test in the United States. There is not enough testing. There is not enough supply chain. There are not enough healthcare personnel. Just earlier this last week, our governor in the state of Maryland opened up to say that if you were asymptomatic and wanted testing just last week, that you would be able to do so. Yet that announcement came at a time in which the public health officials, as well as those leading the testing evaluations at the Baltimore City Health Department, were not ready for that announcement. Were not prepared, had no system in place to make that occur. So communication has struggled throughout this epidemic, particularly as it comes to testing. And as you can see here in the image on the right, healthcare workers, most of the time nurses in this circumstance, all engaged in contact screening and testing in very mobile drive-ins as well as walk-up facilities. That has continued to be, in most parts of at least my state, by appointment only, which identifies and adds barriers. So now bringing you to some of the things that we're doing from a research perspective, and I realize I'm getting short of time here, so I want to speed up a little bit. We are designing and developing, myself, as a nurse scientist and my colleagues in public health and medicine, a population-based estimate in Baltimore to understand the true burden of disease. You've probably seen lots of data around disparities that have emerged. And what we know about cross-sectional and convenient sample evaluations is that they come with an extremely large amount of bias. They're necessary, they're quick, and they're inexpensive, but they come with an exceptional amount of scientific bias. So we are designing this study to help estimate both prevalence and incidence, as well as transmission within households. And I point to you to a very important epidemiologic evaluation from Iceland, who really focused it on targeted testing, and in that circumstance found that Iceland had 13.30% of those tested, 1,200 of the 9,000 people tested were positive in targeted sampling. But when you look at population-based sampling, both an open invitation, come if you want, and random invitation, they found different population estimates, but much lower than targeted sampling. Now, why that's important is that Iceland has a very small population. They have one port of entry, an international airport, and it's extremely easy to do population representative sampling. And so what we've been struggling with, and I sit on one of our governor's task force about how to get a true representation of prevalence in the state of Maryland, is how to do this. And so I'm presenting you today a rigorous approach that has attention to disparities that offers us a population-based impact for both active and passive infection, as well as the potential for reinfection. We hope to give both short and medium-term outcomes for the city, as well as report this data up to the governor, and so that we can actually get in our state or province, as the case may be in your locale, specific detail about what we're finding. And what we're doing in order to make this representative, this is the city of Baltimore. This is our census block groups, or our jurisdictions, and we've divided those by race, ethnicity, and poverty. And the mosaic you see here is the schematic of how that lays out for the city of Baltimore. The lighter greens in the city of Baltimore having a greater than 50% African-American population with greater than 20% household poverty, for example. And there are a total of 453 census block groups in Baltimore City, and we're going to randomly select 105 of those and weight based on probability sampling within each of these categories to get a true random sampling within the population. Our goal is to recruit 1,662 households, including all of these metrics on the right, that will ultimately lead us to collect biological specimens in 1,300 households, including all the biological specimens that you see to your right here, to again evaluate both prevalence and incidence of infection, and then do weekly smartphone application surveys to determine whether or not an individual has developed new symptoms, and if so, repeat all the diagnostic testing through this 12-month cohort. Our ultimate goal is to power the study to have at least 1,000 households still participating at 12 months of follow-up, which will take us through the summer now, because we're starting enrolling in about 2 weeks, through the cold and flu season of the fall into the winter. So when we think about that response, I think the Nursing US response has been formed by both practice and academia, both frontline care with bearing the frontline risk and many sick healthcare workers, as I've discussed. We've had leadership throughout the health system in infection control monitoring, testing and surveillance, education and training. We've also been the voice of alarm, comfort, practice, and science. And I think for academics, that's where we started, the voice of alarm, comfort, practice, and science, and really thinking about how do we shift our educational delivery models, shifting our clinic and practice models. As a nurse practitioner myself, I see all of my patients via telemedicine right now, and had been doing a special study for our HIV prevention patients for the last 2 years to do so. But we've really been supporting the community, standing up, working with the health departments, and trying to figure out how our students could lend an extra hand. But we've already had 6 students, 6 staff, and 6 faculty who have been diagnosed positive with COVID-19. So it's really important that we are practicing wellness throughout our system. But I do want to say that throughout the world, that voice of alarm, practice, science, and comfort has been noted. And here in the United States, we've been represented in nursing in a very wonderfully positive way throughout social media, throughout print media, as well as throughout the digital media, including across all different types of networks throughout the United States and around the world. So I just want to say thank you to all that you do. This is the 2020 International Year of the Nurse and Midwife, and I just really want to praise each and every one of you for all the work that you're doing in the fight against COVID-19 and the fight against all disease around the world on a routine basis. Thank you very much.
Thank you, Dr. Jason, for being so clear and also for being so honest with about the COVID pandemic. We have several questions on the and also some nice comments that that you probably can read afterwards. For instance, attendee from Israel, she's saying that they are in the end of the first wave of the pandemic, actually in Israel, and actually all limitations are cancelled now, and so they starting to go to as normal as possible. But although that the number of new cases are starting to increase, looks like a second wave is coming. And the question is, what are the further steps in the fight with the COVID pandemic?
Yeah, that's a great question. And you know, I'm sure in Israel and around the world, we're facing the same balancing act between opening up economies because there are eventual health consequences for loss of income, loss of work, mental health, substance abuse, and the like that follow any type of pandemic. We know that, we have seen that historically. And so, you know, while my words are critical for our administration about their response to this virus, I also understand the extreme balance that is trying to be found in trying to allow people some level of, number one, normalcy, but number two, this sense of I need to go back to work, I need to open my business, I need to be able to feed my family. And so what really must remain in place is a modification in the way in which we interact with the world. So if we open up, and as we're opening up, we have to think very hard about the things that we do. So for example, thinking about opening businesses, the occupancy level, thinking about how people in the business are allowed or not allowed if they're not wearing a mask. Thinking about how the business does or does not offer hand sanitizer upon entry into that business. Thinking about how grocery carts are wiped down or not wiped down. Are there queues that include social distancing outside of the establishment or not? How is the establishment using natural ventilation to help, helping to clear the air and keep as much fresh air into an environment? Going back to our, what we learned from Florence Nightingale about, the miasmas of infectious disease, making sure that we bring back the fundamentals of an informed population that welcomes these modifications and doesn't fight against these modifications, because the overall point of all the non-pharmaceutical interventions is not restriction of liberty. It is actually just the opposite of that. It is about giving people the opportunity for health. It is not about restricting their liberty. Again, it's the opportunity for health. And so I think that that's what we really need to be messaging, and the voices of nursing must be heard. We must stand up. We must rise. We must not allow our voices to be silenced in this epidemic. It is a critical voice right now across the world.
Okay. Before the last question, because we are running out of time, I would like to thanks to Johns Hopkins for sponsoring this session with Dr. Johnson. Thank you very much. And the other question is there evidence on a linkage between flu vaccination and COVID-19 morbidity and mortality levels?
Yes, so the short answer to that is no. We don't have direct evidence in between influenza immunization. In fact, we're recommending that everyone, as you get ready, hopefully, I'm hopeful that flu vaccine availability will become available as people move into fall season much earlier than typical. And I would highly recommend that everyone receive their influenza and pneumococcal vaccines as early as possible. In your individual jurisdiction, because keep in mind, during cold and flu season, we will have influenza circulating, we will have pneumococcal and streptococcal, disease circulating, and we will have COVID-19 on the scene at the same time without a vaccine. So helping reduce any type of respiratory illness that you may face coming into the cold and flu season will be exceptionally important. So vaccinate for the ones that we have, extremely important. Also making sure you continue to stay in touch with your local and jurisdictional opportunities for engagement. As nurses, I just think you have such an important role to play. Even if it's not COVID related, if it's influenza vaccine related, that is still a really critical role in this response right now.
Okay, I got someone asking, please ask him about nurses being fired. Would you like to comment that, please?
Sure. So we've definitely heard cases of nurses taking a stand against inadequate PPE. We've seen, as I noted, over 300 healthcare worker deaths and over 62,000 healthcare worker illnesses. So their stand against working in an environment that does not protect them is a righteous one. What the health systems have done in places that I have seen has, given the individual the PPE they felt was adequate for the type of exposure the healthcare worker was going to experience, which sometimes the healthcare workers did not agree with, possibly right, possibly wrong. I can't comment about the individual circumstances. But the health system provided the PPE that it thought it could provide or had access to. And when nurses and others, not just nurses, refused to work under those circumstances, the health system fired them. Is that a deplorable condition? Absolutely, yes. Particularly in a circumstance where no one had adequate access to personal protective equipment, and we were all scrambling to find it and continue to do so. I'm waiting on papers for my team and our COVID research study that have been on order for months now. So it's a deplorable circumstance, deplorable situation. I think that the unions in nursing across the United States have used, we are not typically an overwhelmingly unionized population in the United States, but the union have definitely galvanized a lot of support for nurses across many jurisdictions in the United States because of this issue. And I think that it is one of those issues in which a solid, strong, single voice is necessary across the United States and across the world.
Okay, Dr. Jason, thank you very much for your wise words and for the knowledge you leave. Please go to the chat and see the comments that the participants wrote on the chat. And thank you very much.
It's a pleasure to be with you here today.
Thank you.
Hello, I think it's now over to me. Hope you can all hear me.
We can, Professor.
Yes, it looks like you can. I'm Joy Merrill. I'm Professor of Public Health Nursing at Swansea University, and I am the chapter